everybody. I met this man just a few months ago, and he just took me by storm. I actually love this guy, and we're going to talk shoulders today. And if shoulder pain were actually a shoulder problem, we'd probably have it solved by now. But today's guest is treating high-level athletes. He trains clinicians around the world, and he's built a performance model around one uncomfortable idea. Most shoulder rehabs fail because we're asking the wrong questions. And so today we were talking to Josh Satterlee. He's here to challenge how we think about shoulders, from assessment to performance, and why movement patterns matter more than diagnoses. Welcome to the show, buddy.
Hey, thank you. I appreciate it.
So, let's just start off. When somebody says they have shoulder pain, what's the first fork in the road you choose? Stiffness, unstable, irritated, or referred?
Well, I want to give you the most scientific answer to any question, which is it depends. It depends on what they're doing. Yeah. But I would just say, if you're just saying like, where do you treat? You have 1 minute, you're on a sideline or something, and you got to treat something. I would say, I'm going to default to thoracic stiffness. I'm not saying thoracic spine. I'm just saying the thorax is stiff somewhere. Mobilize it and you'll get some traction, I mean, you look at like junior high and high school athletes, right? They're like hunched over looking at their phones and typing all day. And that T-spine and those ribs are just getting stiffed up. If you look at people working in an office, we're all in that kind of front quadrant, praying mantis position, banging on computers. And then it's like, oh, I'm going to go out and I'm going to lift weight overhead and completely take my pecs to end range and whatnot. And I'm like, so I would default to thoracic stiffness. Now, if you want to expand on that, that's look at the T-spine, the segments, are they, extension or rotation or coupled motions? I mean, if I keep going down this path, like the number of women that are going to call in and say, let me get that guy's contact information is just like overwhelming. Because when you're talking coupled motions early in a podcast, like it's pure gold. It's pure gold, But all right, so coupled motions, extension and rotation. And then you think, okay, so let me move outside of the T-spine, right? Then you got the rib heads. They have to elevate and depress. They do a little bit of like upward and downward rotation with breathing, right? And then you think, hey, the ribs themselves, as you go out, they gotta kind of get wider and get narrower. Like the muscles in between the ribs have to allow for movement, and then wrap that all the way around. The ribs end up at the SC joints on the front with the sternum, clavicles, and then what's the only place where the shoulder actually attaches to the skeleton? Yeah, take those old first year of chiro school files and blow them up, the dust off of them. The SC, the sternoclavicular joint, is the only place where the shoulder skeletally attaches to the rest of the skeleton. It's the only bony attachment of the shoulder. So you got to look at that, and that would also include like how the clavicle moves up and down to allow for shoulder motion. And then we can go out to the shoulder, but I'll just tell you this. The reason I don't go out to the shoulder and look at like, external rotation, internal rotation, all that first is how many people do you know, friends, relatives, patients that have had shoulder pain for way more than 4 years and told you, oh yeah, I went to this guy and he treated, I went to this woman, then I went to this massage therapist. They worked and they point to like their shoulder area, their delt. It's like everybody's had shoulder pain. Everybody's had it worked on and nobody's better. So whatever the hell approach we're using is the wrong one. So let's just flip it around. Go central and look distal instead of starting distal and looking central. Besides that, guys, it's been a pleasure being on here, and we'll talk to you later.
I got to tell you, man, Terry, I'm so glad this guy is on the show, because it was only a couple months ago that I started realizing that so many tight thoracic spines are leading to other conditions and may not be coming for a neck problem or a low back problem, but a mid-thoracic problem. And then I started venturing out into the shoulders and, pitchers, tennis players, all those, lopsided sports, golfers. Fix the thoracic spine. It's tighter than tight.
You want to hear something crazy that I learned along the way, Spencer?
Please.
There's a guy named Greg Rose, Dr. Greg Rose. He's an amazing chiropractor. He's at the Titleist Performance Institute, right?
Yep.
And because Titleist is paying their bills, they can afford, $250,000 camera systems to monitor guys. They can afford, $100,000 force plates and all this stuff. And he said, when you look at PGA golfers, now remember, the one thing that's interesting about PGA and pitchers as well is it's an asymmetrical motion, right? Like you're only hitting to one side. Right now you're doing a backswing, but then you're hitting to one side. So we know it's not symmetrical, right? Like running would be symmetrical. So it's this asymmetrical motion. But he said when they put all the fancy sensors on them and they measure all this and stuff, and you look at the thoracic spine, guess how many degrees of asymmetry will appear before there's complaints of pain. So what I'm saying is if you measure the rotation and extension, let's just look at rotation because that's easy to compare side to side, right? Left rotation of the thoracic spine and right rotation of the thoracic spine. How many degrees of asymmetry is allowable before you start getting pain complaints?
Can't wait.
Does that make sense? Does my question make sense? It's kind of a confusing thing, but like how much less to one direction can you turn before golfers start complaining of pain?
No idea.
I would say 1-2 degrees.
0.4. 0.4 degrees. So by the time you and I can see it, it's an asymmetry. Treat it, right?
Wow.
And here's my other question is, how many chiropractors in the world, and I'm talking to all our chiro homies here, how many chiros treat the thoracic spine every single day of their career? As close to 100% as we can get, right? Like,
Right.
There's probably some weirdo who only adjusts feet or something, but like his sandwiches smell bad and when he eats lunch and stuff. So we're not talking to him. But we treat all the time. How many of them measure the motion of the thoracic spine or the thorax daily? Yeah, none. Like you're shaking your head. And that's so common. Terry, you were at my presentation at Pro Sport.
Right.
When I ask everybody who treats the thoracic spine, every hand goes up, right? I mean, it's like the point of pride. It's the easiest thing in the world to do. And it's a great treatment. I'm not saying that. But then like what's normal range of motion for the thorax? And everybody's like, yeah, well, it's really important. I know that. I'm like, yeah, I agree it's important. What's the degree? It's super, we need to measure it. I'm like, I agree. What's the number? It's super, like, that's the most important thing. And it's like, right. So anyways, it's 50 degrees, by the way, 50 degrees of rotation to each side. Rotation and extension are coupled motions. So I just,
For the thoracic only?
Thoracic.
Yeah. So, hey, Josh, I want to get, before Spencer jumps in, if you're talking, 0.4 degrees from right to left, even a goniometer, any type of measurement tool, how can you get that specific for the average person? You can't.
We can't.
No.
That's why I'm saying, like, it only works because they have the, $1 motion capture systems with like, they're putting reflective dots all over the athlete. They're putting little electromagnetic sensors. You and I can't do it in our office. But
no,
when they're saying 0.4, basically, if you can see a difference, treat
there's
it.
a problem. Yeah.
Yeah. I mean, you don't need a goniometer to be like, is this 1.3 or is this 0.9?
Right.
Like, dude, if there's a difference, treat it,
Yeah.
Damn it. I'm thinking about all the patients that have come in over the years, and I go, we can help a little bit, but that mid back is like,
well, here, okay. So let's go back. Let's go back to like, remember when we learned anatomy, right? I mean, Terry, for you, like, what was it? Carter was in office at this point, but we're going way back.
Yeah, but that's okay. Lincoln was in president when Spencer learned it. So,
yeah. By the way, that guy had a great cervical spine. I'll give you that, Spencer. Like, thank you for treating him.
He had Marfan's too. But that's another story.
Go back then. What's the primary curve of the spine? When every baby's born, what's their primary curve? It's that forward kyphosis, right? Yeah. I mean, we could say it's that single kidney bean shape.
Yeah.
All the other ones, like our neck lordosis and our lumbar lordosis, why do we get those? Those are secondary curves. When do we get those? Later. So just think about your own kids. They have a curve. When do they stop getting rid of the singular curve? And when do they go for secondary curves? When they become weight bearing. They don't have that when they're crawling around on all fours because they don't need it. But as soon as they have to bear the weight of their head and their upper body, we develop those secondary curves because now you have this nice S shock absorber, right? It's just a subtle shock absorber. I think about that. Like it doesn't give, but it absorbs shock. So that's why we get them. But in the whole time, from the second you're born, what's the most important motor pattern you do?
Cross crawl.
Before that, and I'll give you a hint. If you don't do it, someone in the room in your first minute's going to smack you on your ass.
Farting.
Breathing.
Oh.
Breathing, right?
Farting.
That I would say that's secondary, and that's a colicky baby. Yeah.
I don't know. I just babysat my 7-month-old granddaughter, so I don't know.
But think about it. Like, breathing is the most important thing we
Right.
start doing, right?
Yeah.
And breathing involves what muscles, what joints, what area.
Intercostals.
That's right. We don't care if you move your legs. We don't care if you move your eyeballs. Like, if you're not breathing, we're going to attack that before anything else in the medical system. And then how many people do you know come into your office and they're so bound up, Spencer, their breathing looks like a labored excursion, right? Like, it's like, how far did you walk to get here? Oh, no, I just parked out 10 feet outside your office.
Right.
You know?
Yeah.
And, yeah. So breathing is so important that, you know, it's one of those things we should probably assess it more and address it. And I'll tell you that if you have somebody with like long persistent shoulder pain, assess their breathing, assess, are they compensating for something? And if you can find the source of the breathing problem, you often find the source of the shoulder problem.
Hey, Josh, we started doing something at the office a couple of months ago, and we started doing blood ox on everybody on their hands. And we would see one side completely different than the other side. And we start working on their mid back and their thoracic,
Yeah.
and we work on until they equaled out. And
Interesting.
so, you know, that was kind of an interesting thought. And I got some of that
Mhm.
actually from you when you were talking about this, that I'm like, well, if we can assess breathing, we have to look at blood ox too. Because if it's
Yeah.
not getting to our extremity on that one side, why? You
Yeah.
know, so
Yeah.
that makes a lot of sense.
Yeah. Yeah. That's an interesting one because there are the mechanical issues of breathing, right? Like, do your bones and joints move enough to inhale? Then, like, can the muscles move those bones and joints to provide enough?
Yeah.
And you have to like fill up if you think of your lungs as a bucket, you have to fill up your bucket enough to sustain life. And then as you do more and more activity, like, you have to fill up more. But as you do that, compensations have to be made surrounding that, right?
Right.
So that's primary, is the mechanical. Then you go to, if you're going to blood ox, you have other layers, like the chemical layer. How many red blood cells do they have or not have? You know, you think about guys who are on testosterone, for example, which is pretty common. They often have, hemochromatosis, where you have too many red blood cells, right? And so that would increase oxygenation, Terry. And then you look at women, like, during their period, are going to almost be anemic. So they're having less red blood cells. And so all these factors come in. But all that is to say, whether you're anemic or you have an overabundance of red blood cells, you still need to mechanically move your bones, joints, and muscles to breathe.
Right.
Stomach breathing versus chest breathing. I hear different things. Do you look at that? If someone's a stomach breather?
Yeah. I would like you to convince the world that I'm a stomach breather, and that's the only reason I have a gut. But, you know, otherwise I would have a six pack. So if we can just like put that out on this episode, you know,
And you're not pregnant,
scientifically, right? Obviously, I'm a picture of health.
You're not pregnant. You're not pregnant, right? That's
No, Spencer,
Not currently.
he has not abs.
Yeah, that's right. Yeah. So that reminds me of a joke. I live in Las Vegas, and there's a town over called Pahrump, and it just has a name of like a small town.
Right.
And Parump's famous because in Nevada still, as if you can believe this, if you have a population less than 100,000, you can have a cat house. And I'm not talking about a veterinary clinic. Yeah. Parump's known for that, right? Anyways, there's a joke that, did you know the toothbrush was invented in Pahrump? Because it was invented anywhere else, it'd be called the teeth brush. Yeah. So, anyways.
Man, I was afraid of where this was going.
Yeah.
I had to think about
I
it.
can't. Yeah. I can't wait for the AI summary of this episode, by the way. Like, I mean, we're going places here, boys. Anyways, let me go back to abdominal breathing or chest breathing, or however you want to think about that. And Spencer, I'll say this. You remember back in the day, like in the 80s, when there was like a lot of like occupational medicine, there was this thought of like spine preserving exercise or spine preserving. And it was like, basically like, whatever you do in work and life, don't flex your spine. So they would teach people to stay in like this neutral spine to bend over and pick up a box. And then they're like, use this lumbar support so you never flex. And I think what we've realized in the last 10 years is you need to flex your spine. You need to extend your spine. You need to rotate your spine. Now, there are dangerous positions, like when you're bearing weight or doing a back squat in the gym, you probably that's not a good time to go into flexion and back out into extension, right? But if you're reaching to bend over and pick up your keys off the ground, you need to flex. Like, you don't want to look like some weirdo idiot, like, don't flex, go down, pick up keys, and then come back up. People are like, dude, what's with this guy? And so I think if we go to like breathing, there are times where you need to do chest breathing. There are times where you need to do abdominal breathing. And there's a study came out in like, I think the Journal of Strength and Conditioning, maybe 3 or 4 years ago. You know, when you run really hard, like if you ever did wind sprints or something in football, or if you played sports, and when you're tired, you lean forward, put your hands on your knees, right? And your coach would be like, oh, don't do that. It admits weakness or whatever. Well, somebody decided to test it, and they found out when you are at a high excursion activity, meaning you're breathing hard, you're breathing deep, that actually is one of the greatest ways to recover. And the thought is, when you put your hands on your knees, let me tell you the mechanics of it. When you bend over, put your hands on your knees, and you lean forward, it's going to basically provide these stilts that lift your shoulders up and gently expand your thoracic cavity. Now, allowing your lungs to inhale and exhale easier than if they had to bear the extra weight of your arms, right? And Spencer, we know you're super buff, so each arm weighs like 50 pounds. But just think, if they're hanging off in space, you have to lift those extra 50 pounds up with every breath and set them down. If instead I prop them up on something, and for those, I'm talking about kind of that, like a position that an umpire in baseball's in, right? That kind of like hands on knees kind of situation. That it goes, you know what? That's a really good way to recover from the activity. Now, it's not a good way to breathe while you're running. You don't want to keep your hands on your knees. But to recover, that seems to actually be better than putting your hands on your head with your fingers interlaced. But again, even if I put my hands on my head, what am I doing? I'm like de-weighting my thorax, right? And so the muscles can catch up. And it'd be like telling a dog not to pant or something. It's like, dude, that's just how we're designed, right? But if you want to go back in time and try and convince your coach you were right the whole time, then best of luck,
Right. The same coach that told you not to drink water during practice.
Well, everybody knows that gives you cramps, man. You don't want to be a sissy. Come on. Yeah.
There are so many revelations in the first 15 minutes of this program. I don't even know what to say. All right, fess up. I need to find out, when did you realize that the thoracic spine was so mechanically involved and integrated into shoulder pain?
I was about 4 years into practice, maybe 5. I was in 4 or 5 years into practice. And I started to notice that I had 3 groups of patients. I would say I had the big 50 to 60% of my patients that are like, hey man, this is awesome. I love what you do. Right. I had the 10 to 20% that, well, I'll say 10% that are just like, oh my God, you're a God. Like every time you touch me, I feel significantly better. Like the middle group is just like, hey, I feel good. It's going to take us a few visits. And then you have those people where you're just hitting home runs with, and they go from, I couldn't walk in here, and now I feel like I can run a marathon. I'm like, oh, I love that. But then the thing that bothered me is I had this like 20%, maybe 30% some weeks that I'm like, these people are saying they're better and I'm doing the same stuff, but I know I'm not really making them that much better. Like, what's going on here? Like they're being nice and they're like, oh, I appreciate it, doc, and stuff. But I'm like, come on, like, you're not that much better. And, like as a professional, I think you want to constantly improve. And you can kind of see it when you make lasagna for your family and you're like, what's it taste like? And like, oh yeah, it's good, but I got to run to my friend's house. And you're like, okay, but I'd rather know at that moment, like, what's wrong with the lasagna? Was it I didn't cook the meat enough? Like, do we need different cheese? Like, I just want to know. It's not offensive to me. I just want to be great. Right. Yeah. So that was happening, and it probably went on for a year. And I was really like, what is it that I'm missing? And so I would go back, and I was an ART practitioner. So I'd look at my ART manuals, like between patients. Right. And I would really be like, well, Terry kind of had this pain pattern. I look at, Travell charts and like where the like, am I getting any insight into like where it extends or where, and those things sometimes are, what would you say? People don't present as a textbook. I'll just say that. So then I'm like thinking about my adjustments and like, okay, is my line of drive different, or could I gap that a little bit? Or like, are there ways to polish that up? And so I would try that, but it would not make a significant dent in the people I couldn't help. Now, again, you have these two other groups that are like pretty good and amazing, right? And I'm like, okay, that's great, but what is it about these people? So anyways, as an ART instructor at the time, I was invited to this ART instructors meeting, and they had these two guys there present, one of whom was Greg Rose, the chiropractor, and the other was a guy named Mike Voigt, who's a physical therapist. Yeah. And I thought it was great because Mike had been involved in a lot of different high-end research and stuff. But he said, like, you can do all this high-end stuff with force plates and MRIs. And he actually was part of a lab where they had an MRI you could run in. Imagine that, an MRI machine. They could record like movement within it. It's massive. It's only for research, but think about what they can look at. And he basically said, hey, all that's great, but I'll just tell you this. For 99% of people, you just need to evaluate each side of, the body, like just compare right to left and look for massive asymmetries. And if you do that, you're going to find most of the problems, not all the problems, but most of them, right? And you think, who's walking into a chiropractic office in your local neighborhood? It's not the person with, it's not the striped, hyperpigmentized pygmy zebra that's walking around, right? It's horses. Like, they say you're here, the beating of hose, you turn and think you'll see horses. Well, that's who it is. So anyways, they just gave a really fast way of evaluating and comparing side to side and for symmetry. And that's called the SFMA, the Selective Functional Movement Assessment, right? SFMA. And I went through that class and I realized, okay, I'm never going to remember anything they said, except for I just need to start comparing right to left, right? And that could be as simple as like, raise your right arm, raise your left arm. Is there a difference, right? And so like, I started going back to my office and I'm like, man, I got to just compare. So I'd start comparing. And I remembered a little bit of the class. Well, as soon as I did that, I found a couple things that were like massive asymmetries I'd missed in patients that I'm already treated. So I'm like they've come in for 10 visits. And now at the 11th one, I'm finally comparing right to left, or like simple stuff, like measuring right SLR to left SLR, right? I mean, basic stuff. And I'm going, oh, that's weird. That's really good. So I'll tell you, Spencer, two that stuck out. I had a patient I was treating for low back pain, and they had everything that looked like essentially disc-based low back pain. No radiculopathy, but just, flexion. They didn't like flexion. All their motions, they said, matched up with this. And I'm like, okay, well, I'll do the SLR side to side. And I would guess it should be limited here, right? And all my treatment up to that point was treating the posterior chain, like, using my thumb to work on the muscles and putting them into adjustments and everything, betting on the fact that their posterior chain is super tight. And this is like a 42-year-old guy who worked in construction, right? What do you think his SLRs look like?
Normal.
Dude, they were excellent. It went up to 90 degrees. He went past 90 degrees. Now, when's the last time you saw a 42-year-old construction worker in jeans do a 90-degree SLR in your office with no knee bend? And I realized, holy crap, I'm treating this guy to get him more mobile. He's already mobile, right? What the hell's going on? What am I doing? And I'm wasting all this treatment. Then I had a lady come in, and she was complaining of shoulder pain. And so she raises her left arm up just into full flexion and abduction, and her right arm up, right? They were perfect. They were perfectly symmetrical, but her shoulder pain on her right side, she said, oh, when I move my right shoulder, man, my neck really hurts, right? Her issue was cervicogenic, but because I never compared, I was treating the shoulder pain was referred from the cervical spine, right? I was treating the shoulder to improve the cervical spine, which it's just unfortunately doesn't flow upstream like that, right? Yeah. Good for business because she's going to need 2,000 appointments before she gets better. Bad for the patient. And so those two stuck out with me, and I'm like, man, I really need to do this. And it kind of hit me like my approach up to this point has been pretty dumb. like just admitting that to yourself, like, it's okay. I mean, I'll get better, but I was dumb. So then I was like, well, I need to take that class again. So I'm kind of hard-headed. And so I took that class 5 times in the next 12 months. And I think I was okay at it by the time of the 5th, but just want to refine it. That was a breakthrough. That year was the biggest breakthrough of my career. I would say, like, if you look at my inflection points, that was the major inflection point in my career. I don't know if you guys have had those, but like I can tell you that was the moment I was like, this is going to change my life.
Oh, unbelievable. I feel like while you're talking, I'm thinking of all the patients that we're just going to focus on the thoracic spine tomorrow and the rest of the, it's again, fascinating and true.
Yeah.
Thank you for sharing that. When a rotator cuff injury comes in, what do you do?
I do the same thing I do with every patient. I ask them to go through the same motions, to just make sure I'm not missing anything major, which is, if they're standing, take your chin down to your chest, lean your head back, turn your head right and left. I just look for those cardinal cervical motions. Are they present and are they symmetrical, right? And then I'll say, all right, let's take your good side, the non-painful side, right? I want you to move your arm like this. And then, so like kind of, for those who are listening and not watching, imagine you're brushing your hair and reaching for your opposite scapula, okay? So that's external rotation, flexion, abduction, and some elbow bend, along with some thoracic motion has to happen, right? You have to go into subtle extension and rotation. Your scapula has to elevate. Like, there's all sorts of shoulder motions going on, but we're just going to wrap it up into brush your hair, touch your opposite shoulder. And then I'm going to do the opposite, which is kind of go behind your back like you're getting handcuffed. Terry, you know this one, but and reach for your opposite scap, right? So I'm just going into internal rotation, extension of the shoulder, a little bit of extension of the thoracic spine, or thorax, I should say, and then some elbow bend. I'm going to look at that on the good side, right? Now, then I'm going to go for the bad side or the complaint side, right? And what should I see? What should they not be able to do, Spencer, if it truly is a rotator cuff tear, right? Or people say it's my rotator cup, I like that one, Now, one of the things we know, if it's a full thickness tear, they should not be able to brush their hair, right? They're never going to get their arm above shoulder height. They're never going to get their elbow above shoulder height. So if all of a sudden they can brush their hair, which has happened, immediately, what are you thinking? It's either not a full thickness tear or something else is going on, right? So I'll do those 2 motions. And I'm going to go through that before I go into any like pinpoint testing, empty can, anything like that. I'm just going to go for these like big, huge ranges of motion that everybody should be able to do. And then I'm going to kind of dive in more. I'm going to go through some other tests. I'm asking them to do full flexion, touch their toes, put your arms up as high as you can, lean back, just looking for like kind of extension of the entire body, the hips, the thorax, the neck, all that stuff. Turn your whole body right, turn your whole body left, stand on your right leg, stand on your left leg, and then squat down. I just do that as like a checklist, right? So in anything, you can improve it with a checklist. I don't know if you guys have ever read Freakonomics. You ever read that book?
No.
Mm-hmm.
Great book. If you there's a story in there where they say they want to see what's better, world-class cardiologists or nurses with a checklist, right? Because they said, like, in cardiac care, so in MI, myocardial infarction, aka heart attack, there's just like a checklist they should go down. So I think it was the Mayo Clinic. They have, in the ER department, they have a group of patients. And for like a 6-month period, if you came into the ER, one group gets sent to these world-class Mayo trained cardiologists, best in the world, right? That's their initial intake. And the other patients, so like odd patients, so evens go to the cardiologist, odds go to the nurse who has a checklist. And all she's doing is asking a series of questions. And no matter which path you went, at the end, they run a EKG on you. They run a ultrasound of your heart. What's that called?
Telemetry.
Yeah, they run all the tests, blood tests and all this stuff. And they say, was this group right? Was this group right? Here's the crazy thing. Predictive success of the nurse with a checklist, 93%. 93% of the time they were accurate by just going down the same questions every time. And they would say, yes, this person has a heart attack, or no, that's an anxiety attack. That person is dealing with, indigestion, right? they were 93% accurate. The world-class cardiologists, 63% of the time. 1 out of every 3 was being misdiagnosed because they, as humans do, we jump to conclusions, right? Oh, I know exactly what this is. And the better you get at medicine, unfortunately, that approach is more and more common, right? I've seen this 1,000 times. And so that stuck with me. At the same time, I'm reading that book at the same time. So I decided, hey, I'm just going to checklist every single patient that comes in. And sometimes it challenges your assumptions. Sometimes that person that says, I've had a rotator cuff tear for years, all of a sudden is like full flexion, abduction of their shoulder. And you're like, that doesn't make sense. That doesn't fit with what I thought, And every time it happens, I realize the world, I don't know about your guys' life, but the world has had a pretty good track record of slapping Josh in the face and saying, don't be dumb right here. You assume the wrong thing here. So that's what I would do, Spencer. Now, if it's confirmed that they can't move their arm, I'm going to go down that path and find out, does any change improve their motion? So, for example, with a rotator cuff tear, why do people, this is going to be a really long answer. So do you guys want to grab a glass of water or anything? Because I don't, yeah.
No,
But let me just ask you this.
Well, good.
Why do they have a rotator cuff tear? Like, think about how did they end up there, right?
Yeah.
In my mind, I'm thinking, okay, the rotator cuff, those muscles fundamentally position the head of the humerus in the scap, right? In the kind of cup of the scap. What do we call that? The
glenoid labrum.
Glenoid fossa, and then the glenoid labrum surrounding that, right? Yeah, so it's layers. That's cool. So why did it tear? It's designed not to tear. Most healthy shoulders can handle all the motion in the world, right? You see baseball pitchers throwing 100 miles an hour. They don't have torn rotator cuffs. You see people working in factories moving heavy objects all the time. They don't have torn rotator cuffs. Why did this person working at a freaking desk get a rotator cuff tear? That's weird. And so I think, what are the mechanics? Well, generally, and this is something I brought up at the talk I met Terry at, is in the shoulder, generally, things that move too much are painful, and areas that are stiff go unnoticed. Let me say that again. Generally, areas that move too much are painful. Areas that are stiff go unnoticed. So Spencer, when you're looking at these people that have stiff thoracic spines, how many of them come in and say, I'm here because it's stiff and uncomfortable? Very rarely. They say, my neck hurts when I turn. And I think, yeah, because you're asking your neck to turn 150% of its normal. In the rotator cuff, you're asking the rotator cuff to aggressively move that head of the humerus into the glenoid, because the glenoid itself, the scapula, is not moving into position because the thorax is stiff and won't let the scapula slide backwards, right? So the only way to compensate is do way too much motion for the supraspinatus or the teres or whatever, those sits muscles, and you ask them to do too much and they tear, right? And so get that scap moving. And by the way, for all those who doubt what I'm saying, think about this. How many people do you know that say, oh, I had a rotator cuff tear, blah, blah, blah. They get surgery. They're good for like 6 months because they're immobilized. And then 6 months later, what do they say? Yeah. I retore it. It still hurts. It came back, blah, blah. Okay. Well, if the problem was the rotator cuff, we addressed that. Why do they still have problems? And it's like, because nobody addressed the thorax. Nobody addressed the lack of motion of the scap, right?
Yeah. Right. I can't wait to treat patients tomorrow.
That's so great. I will tell you, the coolest thing about this is, as a you know what the coolest part for me of being a chiropractor is like, we don't have to play the stupid, I don't want to use a bad word here, the stupid game of let's wait 4 to 6 weeks and see what happens. It's like, no, right now with your head and your hands, do it right now. And is it better? And we have the ability sometimes to get 40, 50, 100% relief of a condition. You know, I'm not saying that one adjustment fixes everybody every time. I'm just saying, like, you can know today if you're making people better. Today. There's no other profession like that, right? Like, if you go to a PT's office and they're having you do the band stuff and they're rubbing your this and that and stuff, it's like, cool, I'll know in 12 weeks if you're any good. I don't know today. But if you go to a good chiropractor, it's like, and they find the joint that needs to move. They know that T4 needs to rotate to the right more for me to get rid of my shoulder pain, and they set you up and they blast T4 and they help it move, you'll know right now, holy crap, that's way different, right? Yeah. I'll tell you a cool chiro story that I'm like proud of. I did some volunteer work with a group called Liga, Liga, the Flying Doctors of Mercy. Super cool group. So they meet up in San Diego, and you fly small planes like Cessnas down to these little villages in Mexico that don't have any medical care. And there's a building on site that's the medical facility, right? A lot of what they're doing is like checking eyes, checking dentistry, and then sometimes they'll get ophthalmologists to do like a special eye surgery for these kids that can't see, or they'll get the cleft palate repair, right? And so it's this crazy group. Sometimes it's just like, hey, we don't have that. We're just doing internal medicine. Hey, sometimes we're doing OBGYN stuff or obstetrics or whatever, right? So anyways, this guy comes to talk to my Rotary Club. I'm in this Rotary Club, and he's talking to me about Liga, Flying Doctors of Mercy. And I go, hey, do you ever, I'm a chiropractor. Do you ever have chiropractors do it? Because he's talking about the cleft palate surgery and these eye surgeries. I'm like, yeah, we can't do that. And he's like, oh man, we love chiropractors. I'm like, really? He's like, oh yeah. He's like, all the time we'll get these bleeding heart orthopedic surgeons who are like retired. He's like, they come down to Mexico. They're a long line of people. He said, oh yeah, this guy needs an MRI and this, I need to get this. And he said, I have to grab him by the shoulder and get like, brother, see that bright light in the sky? That's as good of an imaging as you're going to get today. Okay. So whatever you can see is that's as close to an X-ray MRI as we're going to get, the sun. He said, and they can't do anything. They're hamstrung. He's like, oh, I want to give them this or treatment, and I want to get this gel. And he's like, we got nothing. Do whatever you can right now. And he said, with you chiropractors, man, I give you a park bench. You can treat 200 people today, and they'll be better. He's like, all you need is like your hands and a flat surface, and you're bringing care to the world. And I'm like, hell yeah. Hell yeah. Yeah. The other crazy thing I learned on that trip, by the way, so when you get into these like Cessnas, they're weighing like your bags, they're weighing you. Everybody has to step on a scale, and you kind of have to balance out, right? And they know exactly like this plane can only carry 1,000 pounds or whatever. And I'm a big guy, so they're like, I'm flying. There's no suitcases around me. There's no cans of soda. They're like, let's strip all the weight we can, you know? And they're like telling me to spit and go pee before I get on the plane. They're like, get rid of any weight you can. But anyway, so we're flying, and I'm helping unload a plane, and there's like a stack of newspapers. And I'm like, the hell? Who brought newspapers? Like, think about the heaviest thing that you is just like, I'm like, what the hell is this? And the one dude was like, oh no. If you buy brand new newspapers and you keep them folded, they're sterile inside because of the pressure and the temperature they're printed at. So as soon as you open them up, you can use that as a sterile environment. And I was like, huh? I'm like, when you have discovered that what you need is a stack of fresh newspapers, and that's what you're guaranteeing is a sterile environment. I'm like, wow. This is gangster care, you know?
So cool.
So yeah. But I mean, I treated like, I can't even, I might have treated 150 people in a day. It was crazy, but you can do it. That's the greatest thing being a chiro, dude. You can do it. So
let me ask you a couple of things about, we get patients that come in with frozen shoulder. It's not often, but when they do, man, that is the most miserable. I mean, you know, that's
totally agree.
Seriously, that's the only condition that you have to go past the pain, and that patients are miserable. What would you do if a frozen shoulder came?
Hey, I want to piggyback on that, because you said something a minute ago where most professions, they say just wait for it to go away. The number one thing in frozen shoulder, it has to go through its thawing phase, it's all that phase, and give it 8 months and you'll be fine.
Yeah.
Why?
Yeah.
I mean, it's ridiculous.
I'm like, thank God you guys work at a hospital, or thank God people have medical insurance to come to this visit. Like, can you imagine as a chiro being like, listen, we're going to do some really crappy treatment and not really do anything, but 8 months from now, you're going to keep paying me money. Like, what other situation would anybody agree to that as a customer? Like, I know you came into my restaurant today because you're hungry, and 8 months from now, we're going to serve you the best ziti you've ever had. It's like, no. Call a freaking plumber. Like, hey, I know you called today, but 8 months from now, we'll unclog your toilet. Don't you worry. It's like, you're out of your mind, dude. You are out of your mind. So yeah, I'd go back to this, Spencer. Frozen shoulder sucks. Yeah. It's a tough diagnosis. And one of the ways I always know, like, is it actually frozen shoulders? If the person's willing to put up with that treatment, like you're saying, pushing past, I go, okay, it's good. If they're like hesitant, I'm like, you don't really have frozen shoulder. Like you have a tender shoulder, but like frozen shoulder patients are like, I don't care what you do. Like you can drip lemon juice in my eyes as long as the pain will go away, I'll do it, But I will go back to this. I will say this. Frozen shoulder, number one, violates what I said about things that move too much are painful and things that are stiff. Frozen shoulder usually is painful and strangely lack of range of motion, right? It's one of the weird ones. Okay. The other thing is, in my experience of treating frozen shoulder patients, I find some other area other than the shoulder to treat, and we seem to get a lot of relief. I will tell you this. The next time you have a frozen shoulder patient come in, just ask them to touch their chin to their chest, lean their head back to see if they have full cervical extension, turn all the way right and all the way left. Just check the cardinal ranges of their cervical spine, and I think you will be surprised to see they have a massive asymmetry in their cervical spine. Now, that's not 100% guaranteed that treating that is going to remove some of the issue of their cervical or their frozen shoulder. But I'll ask you this. How uncomfortable is it for you to adjust my cervical spine? Like if I have a stiff cervical spine, I'm the patient you see every day. I come in and lay down on your table, Spence. How uncomfortable is it? It's not at all, right? Like maybe I'm a little sore afterwards. How uncomfortable is it to directly treat a frozen shoulder?
Wicked.
Yeah, like incredibly painful. Yeah. So I would say, how long does it take you to treat a cervical spine if you find an asymmetry? Like let's just say that I can turn 80 degrees left, but when you see my right rotation, I'm stuck at like 20 degrees. How long does it take you to lay me down and adjust?
Seconds.
Yeah, 30 seconds. Okay. In those patients where you find the asymmetry, I would try those things because they might help. They might. And let's assume the worst. They do nothing. What did it cost you? 30 seconds, right? And it's like 30 seconds less that they're going to be biting on the wooden stick and water coming out of their eyes. But what if it reduces 30% of the pain? What if it gives them back 25% range of motion in their shoulder because the cervical spine now moves better? Is that worth it?
Yeah.
And I think, yeah, absolutely. Manipulation is so effective, so fast that I think why not try it? Why, like look for an asymmetry somewhere else, treat that, and then see, did that help us?
Hey, Josh, how often do you find the opposite hip involved?
In shoulder pain or in specifically frozen shoulder?
Frozen shoulder.
That's a good question. I don't have the answer there, but I will say that a very common in athletes, and we might be saying the same thing, Terry, and just from different areas. It's one of the most common causes of shoulder pain in athletes is opposite side lower extremity instability. Meaning if you think about a thrower, they're throwing right arm, their left foot is going forward. Well, if they can't stabilize on that left foot, knee, ankle, hip complex, you will often see an increase of shoulder pain or shoulder dysfunction. If you strengthen and stabilize their lower body, you'll be shocked at how much it improves their shoulder. So this extra motion of trying to stabilize while moving violently fast causes all sorts of pain and tightness. And the deep down root cause is fix the opposite hip. Usually it's a glute issue, but there's going to be some nerds that attack me for what I just said. It's not just glute, it's lower extremity complex. How about that?
Yeah, actually, with pitchers and quarterbacks, we look at the big toe on the throwing side when they come in with a shoulder problem or even a neck problem. It's actually fascinating. My interview, like I'm an alien. I go, just that big toe means a lot to them, So
yeah,
I want to check it out.
I'll say this. Another suggestion I just make to listeners: if you have an athlete, like you're saying, pitchers and quarterbacks and everybody that's struggling, check their big toe. I'm looking for extension of the big toe, right? Well, if you extend your big toe, what are you almost always doing is what we call triple extension. You're in plantar flexion, right, which is extension of the ankle. You're in knee extension, as in it's locked out, and you're in hip extension, which means your glute should be fired, right? That's just like the toe off phase of gait or power. All right, so check their big toe extension, and then ask them to do a glute bridge and do it single leg glute bridge. So you have them go up on both feet and then straighten their left. And that means you're testing the right glute. Just see how long they can go for. You'll be shocked at how many people go 2 seconds and then they grab their low back and they're like, oh, because their glute is not stabilizing, right? So they're overusing their low back or their hamstring. And then I have them go back up on both legs. Now straighten your right leg and check it on the left. It's pretty rare that they are symmetrical and that they can pass. What you're looking for is them to pass 10 seconds. 10 seconds of stability without sagging their hips is normal stability.
I can't wait to do this. Actually, in retrospect, you were talking about the cervical spine, and I just realized I have a 57-year-old male who has shoulder pain. He can't do this. He can do this all day long, and we'll go, supraspinatus impingement and all that. If he cracks his neck, this is his words. If he can crack his neck, he can bring his arm up. I go, what the hell is that? And you are talking about it.
Yeah. I bet he's getting like C6, C7, maybe T1 to move a little bit. And if you just take that train of relief down to T1, 2, 3, 4, 5, he's going to be like, my God, Spencer, you're a god. I feel so great. Yeah.
Hey, let me ask you about night pain. Patients come in, or actually I ask them about, are you sore in the morning, or is the shoulder sore in the morning, or what have you? So what's your approach to their habits when they come in and talking about night pain?
Yeah. Number one, I've had a couple friends die in the last 5 years of cancer. That they were 40 something years old. They reported night pain along with other symptoms, and their PT, their chiro, their primary care just skipped over it because they're like, hey, you're a healthy 43-year-old. So I would say night pain is one of the signs of cancer. So pursue that until you prove it wrong, which shouldn't be too long, but just prove that wrong. Along with that, if you're doing all this treatment of like asymmetries and you're doing good treatment and people are coming back a couple days later with exactly the same symptomatology, to me, I'm like, that's a red flag. I'm pretty freaking good at what I do. I know chiropractic works. I know hands-on manual therapy works. If I'm doing what I think and things are not improving, this ain't a joint muscle problem. Get imaging, ask red flag questions, do all that. So let me just put that to the side, Spencer, because I never did that until my friend started dying. And I'm like, what the F is happening here? Like, how did a friend of mine, 46 years old and died of stage 4 colon cancer, went to 7 different providers, went to a chiro, he had back pain, went to a chiro, then a PT, went back to went to his primary care who gave him some meds, went back to a second PT, went to a hip specialist, and then a nurse at urgent care was like, happened to ask, do you have any blood in your stool? And he's like, I do, but I just assumed it was because I'm on so much ibuprofen. And she's like, we need an MRI. And he had stage 4 colon cancer that probably would have been stage 2 if the first person had slowed down to ask him. So 46 years old, he had 6 weeks to live, and bad times. But it started out as what looked like mechanical low back pain. I want everybody to hear that. Like, just don't get burned by that. It doesn't take long to ask red flag questions. We should do it more often than we do. It sucks. I've missed it. I'm sure we've all missed it. Let's improve, right? All right. Going back to your thing about night pain.
Shoulder night pain, because we could go crazy with all sorts of other pain. But since
think
master.
Lung cancer used to be one of the more common cancers. Luckily, it's on the downhill slope, but there are some lung cancers that can occur and create referred pain. But let's assume you've cleared out the red flags, right? Assume that we're good. Night pain. Okay. I've treated some golfers, and one of the things about treating professional and like semi-pro golfers is golf is actually one of the more high output. So these guys that are playing professionally, you see them on on TV playing Sunday at the Masters, right? But everybody who played Sunday had to play Saturday. And to qualify for Saturday, you had to play Thursday and Friday. So that's 4 days. And then that started Thursday. Well, Wednesday is usually a pro-am tournament for a charity or something where they're raising money, right? So they played Wednesday. And they usually were on site Tuesday to play the course before they saw that. So they've been playing Tuesday through Sunday if they made it, right? Saying that you only get 1 day off, which is Monday. There's very few sports we play for 6 days in a row at a competitive level, right? They've also gone to the range, they've all done this. So the amount of volume is incredibly high, right? You're not going to have an NBA basketball player play six days of games in a row, right? You'd be like, oh, the injury risk is too high. Golfers do it all the time. One of the problems you get into them is like, how do you reduce the volume when it's like you need your shoulder to work in the golf swing? I can't say, well, this week don't use your shoulder in these rounds, but score really well and make money. It's like that doesn't work. So one of the things you realize quickly is like they're not recovering enough at night. And a common one is guys, and I don't know why, it seems to be more guys than women, but guys who sleep on their side with their arm up, right, seem to have longer lasting issues and not resolve as quickly for shoulder problems. So a trick is encourage them to start the night with their hands shoved into the pocket of their pajamas or underneath the waistband of their sweatshirt. A lot of times they'll come back and say, hey, my shoulder actually started feeling good. And I'll say, okay, that's because you had your arm down, right? And it's just not putting stress and blood flow and all this stuff on that shoulder. If they won't do that and they have a girlfriend or wife, I have asked the girlfriend or wife, tie their arm down at night, their symptomatic arm, tie it down with something. I mean, I've gone, like, golfers often have the kind of cotton fabric belts, and so they'll put on a belt, but they'll shove their arm like next to their body with a belt. I've said, just take an old like long sleeve t-shirt, wrap that around, right? And guys will say, yeah, like I'm surprised how often I end up like this, but when I don't, I wake up, my shoulder feels pretty good, right? Yeah.
I agree.
So that's one of the tricks I've used. And then it's tough because like you got to balance those things. Guys who want to sleep on their side and put their arm up, like you can only adjust people's sleep so much, but like sleep, the sheer volume is so important for most of my patients. I struggle for them to just get enough recovery during sleep, So I don't want to adjust your sleep if you're like, I'm only getting 4 hours a night and I'm going to screw up the way you sleep. I'm like, the first thing is get enough hours in the night and then I'll talk about how to make it better. Yeah. But, yeah.
So let me ask you, because based on time, I want to know one of the most common things that we see in the gym, and now it's the new year and everybody's got their resolutions going. Overhead pressing.
Mm-hmm.
Back in the day, it used to be behind the neck pressing. Nobody does
Hell
that
yeah.
anymore because it trashes the neck. So what do you say about overhead pressing?
I would say overhead pressing is awesome. I would say the human body is meant to like reach overhead. I would say that's all great. Asterisk next to that, as long as you have a full range of motion of your entire shoulder and cervical and thoracic spine area, right? Now, if we go, which people working at a computer on Zoom all day have a healthy cervical spine with full range of motion, which have, a healthy full range of their upper extremity and their thoracic spine and thorax and ribs and pecs and lats and posterior elements and anterior elements and sternum, clavicles, and everything has full range of motion. It's like, it's funny as you get into this, it's not the exercise we do that kind of cause the issue. I think the root cause, I don't think that overhead press is the issue. What I think is it's your crappy posture for the other 12, 14 hours a day, sitting curled up, texting, tapping on your computer. And then you're like, well, I'm going to go from the most contracted, tight, horrible position, and I'm going to go do the complete opposite end of the motion spectrum, which would be both arms retracted, reaching overhead with weight. And now my spine has to compensate and stabilize. And you're like, well, the easiest way would be to stabilize by going flexion. No, I need to extend as far as I can. But, your extension sucks because you have this tightness and you've been sitting all day and blah, blah, blah. And I think, yeah, if great exercise, bad person doing it. Like, the lead in 12, 14 hours in front of a computer was a bad way to prep for this exercise. right? So that's my point, you know. But I will say this: if you're somebody that's like, hey, I love, because you ever seen that? There's a great TED talk, and the woman talks about body language, and she says, if you run a race and you cross the finish line, what position do you go into naturally? You put your arms up overhead, you look up, right? Your arms overhead. It's just like a celebration position. This researcher went and looked at like over 100 people that were congenitally blind. They have never in their life seen somebody finish a race. They've never seen it. Their eyes have never worked. Guess what position they go into if they win a race? Arms overhead, looking up like this, right?
That's crazy.
It's in our DNA. It's in our DNA. And if you do a really good adjustment, how many of you have like nailed the adjustment? You put your arms up, right? Like it's just natural. I think, Spencer, that's one of the reasons we love overhead press. Is it feels like, yes, I'm celebrating, right? Like your DNA is saying, put weight overhead. You know, you guys are probably dads, right? When you have your kid and they're safe enough to throw around, isn't it so fun to hold them over your head and like look up at them? Yes. And it's amazing. Anyway, so I think there's this like genetic drive, especially as males, to do that. But if it jacks up your neck or your shoulder, try this. Press one weight, just do a dumbbell, press it overhead, and look at the weight as you go up, because it's going to give you a little bit of cervical rotation. And we know that as your cervical spine rotates to the right, what happens to your thoracic spine? It starts to, on the right side, extend a little bit, and you'll get some relief. So try that.
Brilliant.
Oh, cool.
Yeah.
That's
I know.
So brilliant. All right, Josh, before we go to our favorite section, I do want to leave the audience with a couple of things since they're all pumped up now. What's some 3 exercise or 3 movements that you would tell every rotational athlete or every person to do every morning and every night?
Laterally flex and rotate their thoracic spine. The way I like to do it, drop down on your right knee. Okay, so you're on your right knee, your left foot is in front of you. We call that a half kneeling or split kneeling position, right? And the leg that's in front, turn towards that direction. Once you feel like you can't turn anymore, lean left and right. And then you'll be able to turn more, lean left and right. For all the nerds out there, what you're doing is you're just taking the facet joints and rubbing on them each other, right? And then going a little further, rubbing those facet joints on each other. Get that motion in there. I think that's 1. You wanted 3. The next thing I would do is any motion that combines your thorax, your upper thoracic, with your cervical rotation. So like, are you familiar with the term like open books or like, or John Travolta in Saturday Night Fever, just like moving that way, for the guys with gray hair, that one connected. Yeah. And then a third thing is make sure, these are athletes, right? You asked for athletes. I would say make sure your lower body is stabilizing equally. So do something, a lunge on both sides, a glute bridge, something to just make sure the lower body has awoken. And if you can do it like in the toe off position, it's even better. Like what Spencer was talking about, the big toe. Get that big toe cranking, tighten that booty, and we'll have a lot of success.
All right, I got one more. You got a guy like a pitcher, a golfer, and his one hip is super locked up compared to the other one. What's a morning routine for him to loosen that hip up? Besides 90s.
Yeah. Okay. So just think generally, where does all of our proprioceptive information come from when we're trying to do sports? What are the sensors in our body? I mean, this is again, year 1 chiropractic college stuff, right? But where do our motion sensors in our body come from?
Feet.
They live, we call them mechanoreceptors, Golgi tendon organs, muscle spindles, right? Where are all those? Pretty much you can think they're concentrated around the joints. What's the biggest joint in the body with the most real estate of structure? It's the hip, right? So if I want to stimulate more of those around and make the brain go, oh yeah, this is the hip and I can use it, I need to get all of those things sending information up and a brain sending information down, right? Afferent and efferent. We're getting real nerdy here. But man, the reviews on Apple Podcasts are just be off the charts here, boys. So how do I do that? Okay. Golgi tendon organs need what to trigger a sensation? Stretch. They need tension, right? They need stretch. Muscle spindles need what? Stretch and or contraction, okay? Ruffinian corpuscles, Pacinian corpuscles, right? The Italians in the job. They need pressure. right?
Right.
Mechanoreceptors, what do they need? They need joints to rub on each other, right? They need stimulation. Holding a long, slow stretch only does half that equation, meaning your GTOs and your muscle spindles will feel the tension. But if I want to rub the joint surfaces over each other, get those mechanoreceptors, and I want pressure from the corpuscles, and I want all those things, I think a windshield wiper or a 90-90 stretch, switching from right to left and aggressively twisting the joint capsule will give me the most stimulation. So let me say it differently. Imagine if movement was water inside a towel and you had to get the movement out, getting the water out of that towel. Would you pull it tight? That would help, but what would you immediately start doing? You'd start twisting it, right? Our joint capsules are no different. Twist them, get them tight, and pull as hard as you can. Get that water out. That water is movement. That will help your hips move. I think too many people do these low-level things where the brain's just like boring. I've sat on my ass all day. I've learned to turn that system off. No, you got to start twisting and moving and rubbing those surfaces on each other.
Perfect. Josh is freaking me out here today because I run every Sunday, about 4 miles, and I just recently started doing the windmill thing, and I go, wow, why didn't I do this before? I feel so much more loose just doing a stupid windmill for a couple seconds.
Yeah. Along with that, Spencer, I just got to say this. Back when I started, I've been in practice 18 years. It was really hard to find foam rollers, right? And now they're everywhere. You get them off Amazon, for God's sakes. Yeah. And like foam rollers saw their day, and then all these people were like, well, foam rollers don't actually lengthen the muscles, and it's not going to stretch this. And it's like, yeah, okay. But my current thinking on foam rollers is the reason, because I've had the old patient. I don't know if you've had these guys, like the crowd that's over 65, 70, they're going on golf trips together, traveling. They swear by the foam roller. They're like, oh my God, it helps me. I feel so much looser. What I think is actually happening is I think you're rolling on the foam roller. So you're stimulating those corpuscles, right? You're getting pressure. You're putting them in different positions that they haven't been in, those developmental positions. You guys ever taken a DNS course or like looked at early rehab? It's like, get on the floor, lean on your right arm. McGill's big 3, like get on your side plank. You're kind of asking them to side plank, transition, go front plank, but the foam roller is what they're focusing on. So their brain is getting all this stimulation. And then you start rolling areas you don't use every day. They're rolling the inside of your thigh, rolling the outside of your leg. You're not stimulating those things in day-to-day life. So now we're sending all that information to your brain and going, wake up your motor control system and start using all these areas we stimulated, right? It wouldn't be any different than if you just took like the backside of a comb and just like rubbed every single surface of your body. I think that would probably work the same. The foam roller is just more convenient.
Agreed.
Yeah.
Hey, so here we're at, Terry, we got to make a decision here. The rapid fire questions that we ask at the end of the show, you've answered most of them already. I'm going to switch to the one that you didn't answer. Are you ready? Now it's a rapid fire question, so keep in mind, knowing that you can be a little.
I'm pretty bad at that. Yeah. I am. All right. All right.
Okay. Let me ask you question number 5. When people you've helped are moving well years from now, what do you hope they remember about you beyond those results? Wow.
That I empowered them. Like, go out, do it, man. Do it, load it, do it faster, have fun with it. Pick up your grandkids as you do it.
Nice. Terry, we got one more?
Give him one more.
One more.
This is fantastic.
Josh, you had mentioned some of the movements and that people should do on a daily basis, but is that what you consider movement capacity? Because I know how you feel about exercises and so on. Is movement capacity any of the activities that you've shared? If so, if not, when it comes to shoulders and extremities, what's one movement quality you see clinicians think they're training but are actually missing completely?
This is rapid fire, so this has to be a short answer. Jesus, man, don't ask a 4-part question then with areas to go. I would say when we're talking capacity, the reason we train in the gym is so that you don't wear down as fast. My kid plays football. The reason you strength train in the gym is so that you can deal with more hits. Rory McIlroy is a tiny golfer. He weighs he walks around 140 pounds. He's put on 30 pounds to put up with the rigors of competitive golf over and over and over again, right? So that's why we train. I think that's a great reason to do it. And I think the number one thing, like Gabrielle Lyon and these other people are talking about, that's going to kill people long term is loss of muscle. Yeah. Load your patients. When they're moving well, load them more. And then when they can't do something because it hurts, that's your job. Jump in, fix them with the intent to load them more. Don't back off. I think there's all these people who are like backing off. That's not serving people long term.
Love it.
Yeah. I want my patients to die looking like sprinters, not ultra distance marathon runners, / concentration camp escapees, Right.
Yeah. Perfect. We good, Terry?
We're good, man.
Oh man, Josh, that was extraordinary. Fantastic. Lots of revelation. Thank you so much for your time.
My pleasure.
Yeah, you're great, Josh, as always. Love the laughs, love the humor. Thank you for all you do for our profession, and you'll be remembered as a man that really pushed people to be better. So I appreciate you.
Hey, man, I appreciate you guys getting the word out about it. I've thought I've been pretty smart for a while, but my wife keeps arguing that fact, and when I don't get on podcasts, I can't spread it around. So
love it.
But I really do appreciate this opportunity, guys, and for all the chiros out there, man, we have such amazing skills. We just need to get them out to the right people and don't do dumb stuff that we shouldn't be doing. And if we do that, that's why we've made it this far. The medical profession tried to crush us, except our results are too good. And they're like, damn it, these patients that are getting better just get in the way of all of our ghastly attempts, So
love it.
Yeah.
You have a blessed day, buddy.
You too.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.